Start our look into healthcare this morning with the first of a three-part presentation. Here to lead our discussion is Ms. Green, Chief of our Health Plan Research and Administration Division. Ms. Green, please get us started.
Thank you, and congratulations again, Mr. President.
Thank you.
Good morning, Mr. President, board members, Marta Green, CalPERS team member. I'm excited to be here this morning to introduce our presenter for this session, California Healthcare, Landscape, and Levers for Change. Marian Mulkey is currently an independent consultant to foundations, the public sector, and nonprofit organizations. Most recently, she consulted with the governor's Healthy California for All Task Force, Covered California, the California Department of Managed Healthcare and Consumers Union. She's an expert in California's health insurance market, federal state dynamics and health policy, and regulatory oversight of health insurance in California. Prior to consulting, Marian held progressively responsible positions at the California Healthcare Foundation, an independent philanthropy based in Oakland. Most recently, she was CHCF's Chief Learning Officer, driving efforts to incorporate learning, evaluation, and impact assessment across the organization. Previously, she directed CHCF's work to support California's implementation of the Federal Affordable Care Act, informed state efforts to expand coverage and improve access to healthcare, and analyzed California's uninsured population and health insurance market. Last year, with generous funding support from the California Healthcare Foundation, Marian worked with us, the CalPERS Health Leadership Team, to develop plans and a high-level curriculum for a CalPERS Health Training Academy. The academy will broaden knowledge, hone analytic communication skills, build relationships, and encourage collaboration among CalPERS health staff. Informed by experience serving as the lead faculty facilitator for training academies at the Department of Managed Healthcare and Covered California, yet customized for the CalPERS context, her design will serve as the basis for our own CalPERS Health Training Academy. On a more personal note, I've collaborated with Marian on a number of projects over the years, and I'm thrilled that she's here with us today for this informative session. I know that you will find her engaging, thoughtful, and a wealth of knowledge. I also want to thank the California Healthcare Foundation for their generous support of our training academy and Marian's work on that project. And with that, I'd like to turn it over to Marian.
Thank you so much, Marta, and to all of you. It is a great pleasure to be with you, and good morning. I want to first appreciate CalPERS's dedication to continued development and education among both board leadership as well as your staff team. It's commendable and really a privilege to be able to contribute to the knowledge and learning of such dedicated public servants at both the leadership and staff level. The goal of my presentation today is to share an overview and description of the California healthcare landscape, as well as ways to think about the different influencers within that system. I do want to note that this work builds on some of the insights that I gained from many CalPERS staff members and some outside CalPERS partners whom I interviewed this past summer as I explored and began to develop that training academy that Marta mentioned. Those that I interviewed were very generous with their time and insights, and I really want to acknowledge and appreciate them. Their thoughts did help me better understand how the health system attributes influence and inform the CalPERS context. Next slide, please. So this little mall map, if you will, shows how we plan to spend our time together today. In this first section, I'm going to describe some of the basic features of healthcare financing and delivery in California and in the United States today. Some of this material I know will be well known to many of you, but it may be a useful refresher to others. My hope is that the context offered in this first section will then provide a solid foundation for the remainder of the presentation. After a short break, we'll move on to the second and third parts of the presentation, big picture challenges, and then change levers and influencers. So we'll try to connect some of the problems that are often concerns raised in the healthcare system with the people who have influence over those outcomes. And then after lunch, according to the agenda as I understand it, we'll conclude with opportunities to influence positive change that are particularly appropriate and for which CalPERS is particularly well positioned. Next slide, please. I'd also say that I welcome questions at any point in the presentation. I know the virtual format is difficult, but Mr. Jones, I will certainly look to you or anybody else who wants to interrupt me. Please don't hesitate. And I also want to note that at the end of these sections, we do have time set aside specifically for questions and answers and discussions. So, so I hope that we'll be able to engage at multiple points throughout the presentation. Next slide. So many of the initial slides that I'm going to show you are drawn from data for the United States healthcare system as a whole, usually because specific or timely California data isn't so readily available. But whenever I offer these observations, you can count on the fact that California follows consistent patterns, if not identical data points. The sources of all my slides also are included at the back of the presentation deck for those either among you or in the audience who are interested in where this information comes from. So this first slide shows the inexorable increase in healthcare spending as a share of the total economy over the past 60 years. And it projects it out in the future as well. Today, about 1/6 of all our national financial resources are devoted to some aspect of health and healthcare. And that proportion is forecast to increase to almost 20%, 1/5 by 2028. Next slide, please. This level of healthcare spending amounts to an average of over $11,000 for every person in America for the last year reported. And it's forecast to grow to about $12,000 now, although that does not take into effect whatever may have occurred as a result of the economic recession and pandemic. To put that in context, median US income, again, for that same pre-pandemic period, was about $69,000. So again, just as the resources for the economy as a whole take up about 1/6 of all economic resources, the amount spent on behalf of a person takes up about 1/6 of median income. Of course, the way that money is spent on healthcare is much less visible to most of us and sometimes more indirect than the way that Americans pay a share of their income for rent or groceries. Next slide, please. Switching to a different data source, but still looking at national data, this chart compares US spending per capita to that in other developed countries. The aqua lines are spending by the public sector. So in the US, that would include primarily Medicare and Medicaid, but also public employers such as CalPERS. What's noteworthy here is that US per capita public spending is about the same as public sector spending in countries such as Germany and Switzerland. But then on top of that, the orange bar up above those aqua bars, the US private sector spends almost as much as its public sector does above and beyond that. And finally, the dark blue bar shows that US consumers spend more out of pocket in insurance cost sharing or in direct purchase of care than their counterparts in most, but not all, other countries. Next slide, please. This chart shows how sources of payment have shifted over the past 50 years, since a little after the major federal health care programs, Medicare and Medicaid, were enacted. I'll call your attention here to two things. First, the growth of the green bars. Medicare is the lower light green bar, Medicaid, the darker one, and then other public insurance above that, which together, public purchasers have accounted for an increasing share of our total spend on healthcare, now making up over 40% of total spending. And then the other thing I want to call your attention to is the blue bar, which is the amount that consumers spend out of pocket. What you'll see is that that medium blue bar has declined as a share of the total spend and now stands at about 10% over time. But next slide, please. There's a little bit of a wrinkle to that, which is that at the very same time that consumer out-of-pocket spending has increased, as it has decreased as a share of the total spend, which is shown in that little inset on this slide, it has increased as an absolute amount. So it is both true that on average, consumers are feeling more of a pinch on their budgets, and that the share that they are responsible for of the total amount of healthcare spending has declined. Now, it's important to note, very important to note, that these are aggregate numbers. There's a great deal of variation in how much consumers spend. And of course, if they have more comprehensive coverage, such as CalPERS members coverage, they'll spend less out of pocket. If they're uninsured or have coverage with high deductibles, then they would be paying more. Next slide, please. This stacked bar chart shows in different colors the services to which healthcare spending is devoted. So it's a complicated chart, but I'll just call your attention to the orange on the bottom is hospital spending. It's always been the largest share of healthcare spending, and it has grown over time, but not as rapidly as some other services. There's been a greater shift to services delivered in the outpatient setting, both because there's more ability to treat conditions on an outpatient basis, and because there are more pharmaceuticals and treatments available to do that. All other, the top yellow bar has also increased some over time. This includes personal care services and direct pay. Next slide, please. This chart shows that in California, as throughout the United States, hospital care accounts for the largest share of spending, 36%, with physician and clinical services next at 26%, and prescription drugs, 13%, another substantial share. Purchasers such as CalPERS rightly focus their efforts on these three large spending categories when they're looking for ways to address the rising costs of care and assure that the services that they pay for deliver value for their members or their enrollees. Next slide, please. Over the past 20 years, the average rate of growth for these large spending categories have consistently outstripped the growth of the economy overall. So the yellow line at the bottom of this chart is a reference point. It's the consumer price index or the average rate of inflation, more or less. And the other lines chart the rate of growth for different segments of the healthcare economy. Healthcare services have grown more rapidly almost every year in almost every category than the consumer price index. Although again, this ends in 2018 and you do show a little less growth in the last economic recession as well. What you see here is that hospital care in blue has grown on average 6% per year. Physician clinical services, the light green line, have grown more than 5% per year over this period. And prescription drugs, the dark green line, have grown at an average rate of nearly 7% per year. However, there's a lot of volatility in that. That's the jagged ups and downs. Pharmaceutical spending has been by far the most volatile over this period. And that comes from the introduction of expensive new drugs like biologics and the reduction of costs occasionally for some drugs when they go off patent and can be obtained through less expensive generics. I see a question, so let me take a breath.
Okay, thank you. We had first questions from Mr. Rubalcaba. Mr. Rubalcaba?
Mr. Henry, Mr. Jones, I did not have a question, sorry.
Oh, okay, something came through that says comment, please. Okay, Ms. Yee.
Before.
Thank you, Mr. President. Yes, I just had a question on this chart, and it has to do, you spoke about the volatility with respect to prescription drugs, and I guess I would have expected that the spike that took place, I guess, or the surge that took place around 2015-16 to be sustained in some fashion, but then you see this sharp dip. And
Well,
is it just volatility, or is it what else was happening around that time that may have?
so let me just reinforce that these are rates of growth, right?
Okay.
Still
Okay.
growing. It's not that you lost whatever additional cost came from those new treatments. It's that the rate of growth is not as great as it was before. So this is,
Okay.
so it went up that whatever it was, 12% in 1 year, and then it went up an additional 2.5% in the subsequent year or year after. I can't. So it's building and building and building. You've got the base growing, but the base is growing at different rates.
Got it. Okay. Okay. Thank you.
Shall I resume?
Yes, please.
Next slide, please. So a pause from the numbers, although it will be a short-lived pause. I wanted, before we went much further, to step back and just review some of the unique aspects of health insurance and how we pay for healthcare in the United States. And again, I know this is well known to some of you, but I think it's important foundation to reinforce. As you're likely aware, the share of healthcare paid through insurance has grown enormously since the mid-20th century, partly due to wage and price controls in the World War II era and the tax exclusion of health insurance benefits that provided incentives for employers to invest more in health benefits when they couldn't invest in other areas of compensation. The lion's share of health services are now paid via insurance arrangements. These insurance arrangements have some characteristics in common with property or casualty insurance, but they're also quite distinctive. Nobody, for example, at least nobody I've ever met, buys homeowners insurance hoping or expecting to use it. It's purely a financial protection vehicle. In the case of catastrophe, we want to be protected. We may also buy health insurance in part to protect ourselves from truly random, unforeseeable diagnoses or healthcare needs, such as a car accident or a catastrophic stroke that could never have been forecast. But importantly, we also buy health insurance so that we have ready access to more routine, ongoing healthcare services that we fully know we can predict that we will need and use. So for example, people with diabetes want to be able to access ongoing tests and treatments and whatever other care they may need. Relatedly, another contrast is that when people buy homeowners insurance, the risk of a fire doesn't have much to do with their personal characteristics. One house is about as likely as its neighbors to experience a fire or theft, if we're talking about property damage, property claims. But the chance that you'll need expensive medical services varies dramatically based on your personal characteristics. The odds of requiring an expensive hospitalization might be 1 in 10 for an 85-year-old, but 1 in 100,000 for a healthy 25-year-old. Whereas the odds of having an expensive homeowner's claim are probably something like 1 in 10,000 for all the houses in a particular community. Finally, the features of a homeowner's policy are pretty standard, and they mostly involve dollars and cents. Concepts may be difficult to understand, something like a deductible, how does that work? But they don't depend on consumers' preferences or characteristics. In contrast, health plan details such as network and pharmacy tiering really affect consumers quite differently depending upon their needs and health conditions and preferences. So for all these reasons, the roles of purchasers and consumers play out differently for health insurance than for property insurance. And the public policy framework for health coverage is also quite different. And as I'm sure you know, but as you'll also see in subsequent parts of this presentation, it's more elaborate and more complex. Next slide, please. To illustrate one of those points that I was just making, in particular, healthcare spending differs from the sorts of risks protected by property or casualty insurance. The amount of healthcare used by people of different ages varies dramatically. So on this slide, you see that people over 65 represent 15% of the population, but 35% of healthcare spending, those top two segments in the stacked bars. Even within slightly younger age groups, 33% of the spending is on behalf of people aged 45 to 64, although they make up 26% of the population. In an employer-sponsored plan or some other pooled arrangement, people's health service use is pooled to charge a single premium for the population. In that case, those at lower ages or in healthier conditions are contributing more or having more contributed on their behalf than they're likely to use. And those who are older and sicker contribute or have contributed on their behalf less than they're likely to use. Next slide, please. This chart shows sources of health coverage for Californians of all ages in 2018. Most Californians obtain coverage through an employer arrangement, such as CalPERS, or of course the many, many private employers who arrange health benefits, either through their own work or as a dependent on the coverage of another household member. 30% of Californians now are covered through Medi-Cal, either alone or in a dually eligible arrangement with Medicare. Another 11% of Californians are covered through the federal Medicare program, which, as you know, is primarily available to people 65 and over. 6% of Californians get coverage on their own through the individual market, and that would include people who purchase coverage with or without subsidies through Covered California. The number of uninsured Californians has been falling since the Affordable Care Act was implemented in 2014, but about 3.5 million remain uninsured. And again, this is 2018, pre-pandemic, pre-economic recession. Among those who remain uninsured, about a third are undocumented, and somewhat over 1 million are eligible for Medi-Cal or subsidized coverage through Covered California, but for whatever reason remain uninsured. Next slide, please. So there are important differences that come along with those different sources of coverage for Californians. I want to start by talking about covered benefits, cost sharing, and actuarial value. Covered benefits vary somewhat between the different sources of coverage or between different employer-sponsored plans, but not as much now that the Affordable Care Act has set a floor for minimum benefits. There is a main distinction, though, around cost sharing, the amount of deductibles, co-insurance, or co-payments that enrollees or members bear as a share of total cost. One way to capture in a single number the differences in cost sharing is this concept called actuarial value, the share of cost that's covered through insurance for the average or total population expressed as a percent of total healthcare costs. So Medi-Cal serves low-income Californians and has very minimal cost sharing and an actuarial value that approaches 1. So of all the services delivered through Medi-Cal, almost all of them are paid through the insurance arrangement. Traditional Medicare, without any wraparound benefits from Medi-Cal or an employer or an individually purchased plan, was shown a few years back to have an actuarial value of about 80%. Now, again, lots of Californians do have some supplemental Medicare benefit, and that would increase that actuarial value. Reflecting the comprehensive nature of CalPERS benefits, the actuarial value of CalPERS HMO products is about 96%, meaning that on average, across the entire enrolled population, members would be responsible for only about 4% of the cost of covered services. And PPO products have actuarial values for CalPERS in the 85 to 92% range, which is still quite generous compared to employer-sponsored plans. I see a question.
Yeah, thank you. The question is from me. And back to your slide 14, next
Yes.
previous slide.
Yes.
The looking at the percentages, and I'm looking at the uninsured and the private, the 7 and 6%. So when they're talking, I know this, I recognize this is California data, but the question really references the entire U.S. So when they're talking about health care for all, are they looking at the increased costs of those two components, uninsured and private, or are they talking about funding all of the costs, even though it's already being provided by the employer?
Well, that's a complicated question because I think different people might use the term in different ways, but certainly there can be two policy goals. One is to get everyone covered somehow or other, universal coverage. Another goal can be to consolidate the financing of healthcare services so that everybody receives the same benefits and all providers are paid in the same way, and there's really a single payer or a unified financing approach that has equal rules for everyone. And people might mean different things depending on the context or the exact words they use. Is that helpful, Mr. Jones?
Yes, okay, that is. So organizations, employers, then under healthcare for all will still be, and I'm interpreting your response correctly, will still be paying into that cost of coverage for all.
Well, I think there's a huge question about what the remaining role would be in any sweeping reform intended to expand coverage to all. In California, to date, the policy has all been sort of incremental. Let's build on all the programs that cover people now and either expand them to more people or fill in the cracks. And that was generally the philosophy of the Affordable Care Act as well. If you talk about something like Senator Sanders' single payer type concepts, that might bring bigger changes for employer sponsored coverage, but they are far on the horizon, I would suggest.
Okay, thank you very much.
You're welcome. All right. I just wanted to make one last point on this slide, which is that when you talk about actuarial value and the relative generosity or comprehensiveness of healthcare benefits, that tries to capture the financial aspects of health coverage. But the less tangible, but very important to human characteristics of health benefits are not captured there. So notably among those is the network design. So you could have two products with the same actuarial value that have very different networks and have different benefits is the wrong word, sorry, and are experienced differently by people who interact with those networks differently. So right now, I'll say a little bit more as we go about networks as a way to address costs and value. But for now, I just want to note that provider network can be a major differentiator, along with softer things like customer service. Next slide, please. So the Affordable Care Act, I gave you a little preview of this in my response to Mr. Jones. The Affordable Care Act was, of course, a major federal law passed in 2010 and implemented in 2014, also known sometimes as Obamacare, that substantially altered the rules of engagement in the overall healthcare market, and yet maintains the fundamental role of market players in arranging and delivering health insurance and healthcare. A primary focus of the Affordable Care Act was the individual market. So that 6% of the California pie back on the slide we previously saw. So it was intended to assure that people not eligible for employer coverage or a public program would have improved access to the individual market or to an expanded Medicaid program. Prior to the passage of the Affordable Care Act, the individual market was deeply flawed. People could be turned down, charged dramatically more based on their health conditions. The law has brought many more people, including about 3 or 4 million Californians, into coverage through the combination of the expansion in the Medi-Cal program and in the individual market, guaranteed issue, which means that plans have to sell to everybody, subsidies, federally funded subsidies available to people who meet income criterion, and an individual market penalty, which was imposed at the federal level until this past year when California enacted its own individual market penalty, which means that individual mandate penalty, which means that if you don't have coverage, you can be subject to a penalty. The Affordable Care Act also leveled the playing field in terms of establishing essential health benefits, a floor again that all coverage must comply with, and it set some affordability requirements for employer-sponsored coverage. But because CalPERS benefits were comprehensive prior to the ACA and as premium contributions low, the law had limited direct effect on CalPERS. Although I would note that it helps stabilize population and access to coverage system-wide, which has beneficial effects for Californians as a whole and has an impact on providers, as we'll see in some parts of the subsequent presentation. Next slide, please. A number of aspects of how healthcare is delivered in California are foundational to understanding the current status and prospects for improvement within our healthcare system. First, where consumers typically obtain care varies by types of coverage, as do provider payment rates. This means that one payer's efforts to address access to care or payment can have spillover effects, either negative or positive, on other payers and populations. The healthcare workforce in California is not well positioned to meet future healthcare needs. And so the point here is that delivery arrangements, kind of where we are now, the status quo, has to be factored in when you think about how we might improve either for subsets of the population or for the system as a whole. Healthcare providers, as noted here, are unevenly distributed, with rural areas and the Central Valley and the Inland Empire generally having fewer doctors and other important healthcare providers than coastal areas. There's a long-standing over-reliance in California, but throughout the US, on specialty care versus primary care services. We have many more specialty care providers as a proportion of the share of physicians than counterparts in other developed countries. And the current workforce is not reflective of the state's considerable racial and ethnic diversity, and we'll hear more about that as we go forward as well. California has also, for many decades, had a much higher reliance on managed care and integrated delivery systems, those arrangements that have established networks and have coordination of healthcare services through a primary care provider than have many other parts of the country. Managed care arrangements in California typically incorporate financial incentives such as full or partial capitation that are intended to encourage less service use and greater investments in preventive care, but they also have the effect of influencing the extent to which consumers can exercise just independent choice and go directly to providers. Mr. Jones? I think you're still muted, sir.
Thank you. The over-reliance on specialty rather than primary care, that discrepancy, I would assume, will continue to exist or even widen because of the lucrativeness of focusing on specialty rather than primary care. So what is the solution to that if we recognize that specialty will continue to outpace primary care?
Yes, you are exactly right that has grown over years in response to a constellation of incentives. Medicare provides, reimburses specialists at higher rates. The lifelong earning potential of a doctor who specializes is considerably greater than that of one who is in primary care. The solutions may be system-wide, that is a shift in some of those reimbursement arrangements, so influence through public policy and the regulatory process on the Medicare process, perhaps. Investments in workforce development. Again, these are not something that I would imagine an individual purchaser such as CalPERS could individually do, but it could certainly contribute to public policy debates and solutions beyond its walls to improve that system. And then there's certainly also been considerable investment in workforce to supplement the physician workforce. So looking at ways to take greater advantage of or better reimburse community health workers, promotores, people who can be supplemental assisters to the process. Next slide, please. So a long-standing feature, and in some cases concern, of California's healthcare system is the substantial differential in costs and premiums across regions of the state. This heat map chart is actually based on internal CalPERS rating data. It shows that in the southern counties, total costs are as much as 35% lower than the statewide average. Whereas in Sacramento, costs are slightly above average, in the Bay Area, further above average, and in Monterey County, that bright red county, more than 50% above the statewide average costs. Different factors contribute to the cost profile of hospitals and healthcare providers in different counties, but a key influencer, as we'll learn a little bit more later in the presentation, is the degree of competition in the market and the extent to which providers can command prices that might be called monopoly prices because of their position in the marketplace. Next slide, please. I mentioned earlier that people's source of coverage or payer, whether they get their coverage through private employers or Medi-Cal or Medicare, influences their usual source of care. Relatedly, the willingness of providers to accept new patients varies based on the patient's payer. Enrollees under private insurance arrangements such as CalPERS and other employer plans are generally the most welcomed by both primary care providers and specialists. And physicians are somewhat less likely to accept new Medi-Cal patients or uninsured patients. Patients are sorted across hospitals based on their coverage as well as where they live and what physicians refer them to those hospitals. And that means that hospitals rely to varying degrees on public versus private payers. Again, this is important context because when you seek to exert influence or when other payers seek to exert influence, it can have spillover effects on the market as a whole. Next slide, please. Importantly, private payers reimburse healthcare providers, both inpatient and outpatient, much more than does Medicare. Through its legal authority as a federal program, Medicare has established price-setting formulas that are imposed across all facilities in essentially a take-it-or-leave-it approach. And needless to say, hospitals are generally in the position of taking it because Medicare is such a key payer for the people who are most likely to need hospital care. These data points from a RAND comparison of facility prices for the commercially uninsured population show that on average across the nation, standardized negotiated prices for commercial payments, that is employer-sponsored plans such as CalPERS, are now nearly 2.5 times as high as the rates paid by Medicare for the same procedures and facilities. Next slide. And using California data and a different analytic approach, researchers have also shown that California hospital payments from private payers are about twice as high as payments by Medicare and Medi-Cal. This is sometimes referred to as a cost shift, wherein reimbursement for privately insured patients covers some of the costs incurred for care to Medicare or Medi-Cal patients. So, next slide. To summarize this first part, this is sort of a whirlwind trip through some of the features of the landscape in which CalPERS health benefits exist. I've tried to give some of the key characteristics of the structure of healthcare financing and delivery. And I would summarize as follows. Payment matters in terms of where people get care and how much their providers are paid. Because we rely on market arrangements, providers can exert some leverage depending on their particular market realities. A market-driven approach also means that some consumers and some providers can exercise choice, and they can vote with their feet, so to speak, about, in the case of providers, who they serve, and in the case of consumers, where they get care. But that ability to act as a free-flowing market player is constrained by people based on the details of coverage arrangements and by the amount of competition on the provider side. The complexity and fragmentation of different payers and delivery system actors means that system shortcomings in terms of cost, quality, access, and equity, which is where we're going to go in the second part of this presentation, can be extremely difficult to address. We'll outline some of those challenges in the coming sections and explore who holds leverage to address them. So now I'd be pleased to answer questions that look like they're already going to come in, or any questions on this first section.
Mr. Miller, please.
Yes, thank you. The presentation is very enlightening, and the refresher is very welcome as well. My question kind of goes to issues surrounding when we negotiate. When thinking about the differentials between, say, the private pay and public pay, and when we look at the providers, we're always trying to have an understanding of trying to kind of get under the hood with them and have a sense of, how much are we overpaying? How much are we subsidizing things? And looking at specific services or activities. For example, an example I'm real familiar with is birthing centers and maternity. And there's a dramatic difference between what someone walking in to a given facility paying cash or with private insurance pays versus someone on Medicare, Medi-Cal. And so could you share with us a little thoughts about the actual margin for those services versus what the higher paying customers are paying versus the reality of the margin? I know, for example, certain birthing centers in certain big city hospitals have had gross margins for birthing babies of, well, I won't give a number, but it's really substantial. I mean, north of 30%. And it's reflected in those differences. So how do we kind of approach that or get under the hood? Or do you have a sense of how that works for?
Yeah, I mean, I understand the concern and would very much share it in your situation. I can't claim that I am an expert either in the facility-specific financing and thus the margins that you're talking about, or in the negotiating techniques that are or aren't available to you. I would, and perhaps members of your health leadership team will want to jump in on this, but I would suggest that there is an element of what the market will bear here, and if you're in a position where you have differentiated yourself as a healthcare provider as being, a highly valued by consumers and a must-have in terms of commercial networks, either because there's nobody else like you in a particular region or because you have established such a reputation that people demand you, you can command a price that is probably over your costs. And there is also some suspicion, I think, that that some providers deliver services up to whatever they're being reimbursed with, as opposed to driving costs down to the most efficient level. And again, I think that varies very much facility to facility and market to market. And I wouldn't want to speak to any particular actor, but I do think that that in this fragmented system, that sort of activity can occur.
Yeah, and I worry that because one of the big measures, as you mentioned, that everybody in the business looks at is their payer mix, and I kind of worry that as such a big institutional provider, or well, uh, providing access to providers for our members, that we're not unintentionally kind of making things worse by kind of pushing more of our business to the folks that have the better payer mix, and it becomes kind of a chicken and egg thing that, as a society as a whole or a state as a whole, in the long run, I would hope we move to some sort of more universal, more equitable situation. But it's kind of mixed feelings. Our drive to get the best deal and to not subsidize the care of folks who aren't our members can also kind of work against our better angels in terms of improving healthcare for all. So it's always challenging because the providers
Yes.
can really hide the ball in terms of what their real margin is for any given book of work within their organization. And
Thank you, Mr. Miller. And I would say that kind of encapsulates the dilemma that almost everybody who participates in the healthcare system has, which is in the aggregate, we'd like to see many universal, equitable, efficient outcomes, but we individually must serve the missions of the organizations we're in or respond to the financial realities that that allow us to remain in the organizations we're in, right? So that is the tension of the system that has grown up around us.
thank you.
Okay, Ms. Yee.
Thank you, Mr. Jones. Thank you, Ms. Melke, for a really provocative presentation. I've got all kinds of questions floating in my head, but one really related to, I think, I guess, a public policy drive, as well as some conversations we've been having here at CalPERS about the role of transparency. And so if there is greater transparency demanded over prices and quality of care, that presumably would help drive prices or keep prices down and costs down. Even though I think from a consumer perspective, I'm not so sure that those who are requiring care urgently would think to look at price comps. But and then how that really runs up against your earlier slide about the increasing reliance on specialists. And so I guess I just wanted to know, is transparency kind of an elusive lever? Because it seems like we're not necessarily going to get to the point of where we really have true comparisons.
Yeah, I think there are many things that are good about transparency, but it is not a panacea, is the way I would put it. And I would, and I actually, when we get to the end of these many parts of this long presentation, I will come back to that and offer a few more observations. Transparency only goes so far, because if you're talking about these issues of really uneven market leverage, knowing what is being paid doesn't necessarily allow you to pay less. And if you have these differentials, you and others are in a position based on their government status that they can pay differently than you can. That too is a reality that is hard, that can't be overcome by transparency alone. Right. That said, I think transparency is a hugely important tool to really get under the hood, as you say, about where the cost drivers are, and to the extent that you can, where those are commensurate with differences in value or consumer experience versus where they seem to be disassociated with any value or benefit. And so I think digging into that data is very, very important, even if it is not alone the solution.
Mhm. Do you think we'll ever get to a point of where that balance between specialty care and primary care can be readjusted as a result of transparency?
I think so. I mean, I think it is pretty out of balance, and I do think that there are a lot of interests, and there's a lot of reason that there are many public policy factors pushing on a change in that. As with so many things, and similar to your question earlier, it's kind of the rate of change. It won't change overnight, but it might quit getting worse and perhaps start getting better.
Got it. Great, thank
Marion,
you.
if I could add something on the issue of balance between specialty and primary. Also, California is well positioned because of the penetration of managed care and the reimbursement rates for doing capitation for primary and specialty within group practice areas can also help balance. So as we continue to expand managed care penetration and move away from fee-for-service reimbursement, we can also, just as a matter of public policy, better balance the two with those reimbursement policies.
Yeah, that's a great point. Thank you, Mary.
Thanks, Marta. Yes, I agree.
Thank you.
Ms. Oliveris?
Thank you. Really interesting presentation. I think we're at a critical juncture with MedTech right now as well. And over time, I know that the cost of healthcare has changed with things like advertising, for example, of pharmaceuticals. And now that we're in this rapid explosion of MedTech when it comes to wearables or in-home diagnostic technology or apps now for mental health care, how do you see the cost of insurance changing as it's becoming essentially more distributed in terms of medical care? And it's starting to look different. Do you see the cost of insurance actually declining over time, or do you see like an initial spike because of higher advertising costs?
Really intriguing question, and I have to say I haven't spent a lot of time thinking about it. So this is more of a another consumer just speculating rather than based on any particular expertise. My sense is that a lot of those services are at this point being marketed more as direct to consumer approaches, and thus probably won't have on health insurance or on aggregate healthcare spending, that they're a little bit of a parallel track as opposed to core to what's driving healthcare spending at present. But I think there are some interesting implications in terms of preventive care. There are also perhaps some worrisome implications in terms of equity around who gets those, who uses those, who clamors for them versus and who can benefit from them versus who is left out. So those are just off the cuff comments, but I am intrigued by the question and I may be prompted to want to learn more.
And Marion, if I can add again, sorry.
Not at all.
Wearing my old DMHC hat, this came up. This was an every week conversation when a new device would come to market and whether or not it was what's considered a basic healthcare service. So should it be covered by a managed care plan? And there would be an extensive analysis. And there's one that comes to mind that was it was essentially a hat that was cancer treatment. So it was a hat that was connected to essentially a briefcase that helped treat a very specific form of brain cancer. And normally this was done in either an outpatient or inpatient setting, but you had to be hooked up to a device for up to 12 hours, but could you do it at home and would it allow the freedom? And so there was an entire analysis done by the DMHC about whether or not it was a basic healthcare service. So there are those discrete services where those direct-to-consumer devices may become basic healthcare services and could influence insurance prices. So there's those things that straddle the line that may end up influencing prices and also could positively impact the outcome for certain consumers. And so there's those that do drive what Marion just described, the inequity, those people that can afford it, and those that become basic healthcare services and then do drive insurance prices.
Thanks, Marta. I appreciate that distinction.
I'll add also just to pile onto the conversation. We did a good amount of work on MedTech and at the Commonwealth Fund while I was there, and certainly in the early days and even now, a lot of it was directed at young and healthy people. To maximize their health, which is not where the healthcare dollars are. They're in older folks with more complex conditions. There has been some movement in that direction, understanding that population and pairing developers who tend to be young and disproportionately male to that population has been, but there's a lot of promise in that particular area because there is a lot of opportunity in meeting people where they live and improving their healthcare. And there's some evidence that if you do it well, you can keep them out of hospitals, which is a key to reducing costs. So there's opportunity there, and you can see cost saving potentially there. So that's where I'm hoping it will go. It's also promising in the long-term care space.
Thank you. Very interesting.
I see no additional questions from board members. So at this time, I'll ask Mr. Fox whether or not we have anybody from the public who wish to comment on this section. Mr. Fox? Okay, check it out.
The host would like you to unmute your microphone. You can press.
Mr. Fox, are there any members from the public who wish to comment on this section? You're muted, Mr. Fox.
Can you hear now?
Yes, I can.
Okay, stand by just a moment. Okay, we have one caller.
Okay, you could go ahead and allow the caller to speak, and the caller will have 3 minutes.
You can press *6 to unmute.
Okay, Mr. President, can you hear me now?
Yes, we can.
Hello? Can you hear me?
You're muted now, Mr. Fox.
I think he's trying to fix the echo.
Hello?
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 Hello, can you hear me?
Yeah, this is Larry Woodson. Can you hear me?
Okay, yes, we can hear you, Mr. Woodson. You may go ahead and proceed. You will have 3 minutes.
Oh, okay. I'm sorry. I was having some technical issues here. Larry Woodson, California State Retirees, Chair of the Health Benefits Committee. And I just wanted to start out by thanking Ms. Mulkey for her presentation and look forward to the rest of it. I have 2 questions, and you may address these later, but I'll ask them now. They have to do with cost influencers, and both for health care in general and also drug costs. And so first, and I've raised this question before, but there's been information lately about private equity firms investing heavily in healthcare provider types of healthcare providers, including urgent care, nursing homes, provider practices, and particularly ER doctors, which has led to a lot of surprise medical billing. But my question is, are you aware, Ms. Mulkey, of how great of influence this has on pushing costs upward? They're in it for profit, obviously, and it is increasing costs to us and I think, just overall. And are there any efforts short of, trying to regulate profits, which isn't going to happen, or short of a single payer system to address this legislatively? And then my second question is with drug costs. Current patent law, Big Pharma is able to slightly tweak their brand name drugs when they're approaching the 10-year patent expiration date and just gain new patents on essentially the same drugs. And I heard a TED talk on this, and the only way that it appears that this can be addressed is through some kind of legislation and change in patent law. And I'm just wondering, this apparently has a big influence on drug costs because it shuts generic competition out. Do you have any comments on that as well, and the degree of influence it has on pushing drug costs up? Thank you.
Do you want me to just
Yes,
jump
go ahead.
So again, I can't. If you wanted the presentation on how to peel apart all the different sources of healthcare cost drivers, that's not what you got today and not what you're going to get. But I will agree that everybody responds to the financial incentives. All participants in the market respond to the financial incentives that are before them, and the incentives of a private equity investor to get in and out with as much financial reward as possible are skewed for the short term compared to other healthcare players, and are financial in nature in most cases, without a great grounding in mission or in human impact. So I do think it's a worrisome trend. I can't really speak to how big it is in terms of the overall sea of healthcare cost drivers. I think more. It is the general factors that drive higher and higher healthcare spending cut across the particular players, in my view. So they are bigger than those issues, but those kinds of arrangements contribute to them. And I would say essentially the same thing to the question about pharmaceutical patent law. It is worrisome that higher prices can be charged for drugs that don't have a lot of incremental clinical benefit. I do think, as far as I'm aware, the only remedy to that has to do with federal statutory change and regulatory adjustments. But again, your expert healthcare staff may have more to add on both of these points.
On the first point, I would just add that when you look at our data, so the heat map that Marion provided, or the RAND study that she referenced that also used our data along with other major purchasers. If you look at any specific healthcare market and you look across all of the healthcare providers in that market, the general trend for each market relative to the percentage of Medicare that they can command is market-wide and isn't tied to whether or not they're owned by private equity or they're a nonprofit. Or they're a for-profit physician-owned entity, but instead is about the market forces within that entity and the relative prestige of the organization. And so I think Marion makes an excellent point that those are really worrisome general problems within the healthcare market, but really when it comes down to whether or not a specific entity can command 100% of Medicare or 450% of Medicare has much more to do with what is happening in that healthcare market specifically and the profile of the entity. You know, the Cedars-Sinais of the world are always going to be able to command the 450% of Medicare versus, you know, the hospital up the street, as an example. And as our heat map showed in Monterey County specifically, those prices for every provider that is operating in that county are higher across the board. And so whether or not they're owned by private equity, a nonprofit, or owned by a physician group. So that was the point I would just add based on our data, and we see it across the board.
And Larry, yes, evergreening is a problem for us. It's another example of a way in which competition is artificially kept out of a market. And anytime that happens, our prices go up.
Okay, thank you for those responses. And so at this time, let's take a break and reconvene at 10:45 before we move into part two, the big picture challenges. See you in about a little over 15 minutes.